Hi everyone, and welcome to this video on what to do after you've diagnosed a substance use disorder. Before we begin, remember that patient-centered care means that we are always involving patients in every step of the way. We're asking their opinions, and we are making sure that they have consented to everything that we are doing. Really important with addiction medicine always to be checking your own biases and managing your own countertransference. There's a lot of stigma with addiction medicine, and that stigma lives inside of all of us too. So we always want to make sure that we are not allowing any of that stigma to impact our patients. If you have any questions or patient-specific issues, please contact an addiction medicine specialist. These are educational videos. Of course, this is not patient-specific advice, and you are still responsible for your own practice. I do not have any conflicts of interest to disclose. No drug companies pay me. Okay, so let's talk about the stages of change. So you know that someone has a substance use disorder. You have diagnosed them with that, and they are like, you are trying to get a sense of what their understanding of this is. So when you are getting a sense of someone's stage of change, they might be pre-contemplative and they might be like, nope, that is not me. I have no interest in this. This is not something I am going to be part of. I do not have a problem. That's fine. It doesn't mean that they don't have a substance use disorder. It means that you have now assessed where they are at in terms of seeking treatment. They might have be like, well, yeah, I know it's a problem, but eventually I'll change. Right now, I just want to kind of keep things the way they are. They might be like, oh yeah, I have a plan to quit. I'm quitting next week after my surgery. They might be like, oh, I have a treatment date tomorrow. Or they might be like, yeah, I've had this substance use disorder. I have not used any substances in the last 3 months. I am totally abstinent, but I'm still working on this. I'm working on that maintenance part. And of course, we talk about relapse as an expected part of recovery. Addiction, of course, is a chronic illness, right? So it's chronic relapsing remitting illness. We do expect relapses to happen. We want to minimize the harm of each relapse. We want to space out relapses as far as we can. That's our goal. So a patient might be anywhere along this addiction spectrum, headed in either direction. So when they might come in and need hospitalization for some other reason. They might come into your family medicine clinic for a different reason. So you can still get a sense of where they're at, and then you tailor your interventions based on where they're at. So let's say you have a pre-contemplative patient who plans to continue using, has no plans to stop using in the future. Your interventions are going to be around, how do I reduce the harm of this substance use? So how do I make sure, are you using sterile supplies? Are you using a supervised consumption site? Are you using alone? Do you take test doses? Do you try and keep the same batch? Do you stagger your doses when you're using with other people? Do you have a naloxone kit with you? Do you use any of the apps like the DOORS or the NORS harm reduction apps? Very, very important to make sure you're asking all these questions, and those are your opportunities for intervention, because you cannot help anyone or provide treatment if they are dead. So your goal is to make sure that people are alive still. For people who are using or contemplative, and let's say they're using alcohol, you're going to want to make sure that they're aware that alcohol stopping cold turkey will require medical management. You cannot and should not stop cold turkey just on your own without consulting a doctor. So that's, again, like an intervention of education that you can provide this patient to try and keep them alive. Maybe they're on the total abstinence end of the spectrum. They've been abstinent for the last 5 years. They have a substance use disorder in remission. So then you are going to make sure that you are supporting them with abstinence-based treatment. We're always going to make sure that we're tailoring our interventions to the patient. Now, you could have been abstinent for 3 years and you might still have a relapse. And in fact, that relapse is much more likely to kill you if it's a relapse to opioids. So we still want to make sure that our abstinent patients know what to do in case of relapse. So how do you relapse safely? How do you stay alive through a relapse? Because we know that, remember, addiction is a chronic issue and that relapse may happen. And so we're always just going to make sure that people stay alive. Okay, so what we also need to figure out in that same spectrum is, which direction is the patient wanting to head? Maybe the patient has been abstinent for a while and they're like, this abstinence thing, I am not into it. I'm planning to start using again next week when my buddies come to town. You can do all you want for like motivational interviewing to try and ensure that the patient changes their mind, but you still can't control that patient. So if you know they're heading in a different direction, you're trying to get ahead of that, try and make sure that they still feel comfortable accessing medical care in the future if need be, and B, that they stay alive through their relapse. So just going to target those interventions based on the patient goals. Let's say the patient is like, oh, I'm planning to still keep using now, but my goal is to get housing. My goal is to get medical coverage so that I can go on OAT so that I don't have to keep using illicit substances. Things like that. So we're going to try and always determine that patient's goals and assist them. Assessing their social situation is a huge part of it. I had a resident one time, we were going to go see a patient, and the resident was like, you know, you just need to stop using your meth. And the patient was like, I live outside, and every time I don't use meth at nighttime, I seem to get raped because I fall asleep and I'm vulnerable. So I have to use the meth unless you're going to house me. So sometimes the substance is not like the big thing on a patient's mind. So you're always going to want to get a sense of how else can you help support. And of course, we're also going to advocate for patients to receive that appropriate medical care. So just because someone has a concurrent substance use disorder, if they're using or not, they should not be declined medical care. So really important that we're advocating for that. Lots of times things get hidden under substances. So oh, like you've been falling a lot and passing out, like, well, it's probably because you're using opioids a lot, you're probably overdosing. And then we determine like, oh, there's also an arrhythmia there too. So we're not just going to blame the substances without ruling out everything else as well. So every medication we provide has a risk and a benefit. So the risks and the benefits both change a lot based on a lot of different factors. The risk of prescribing methadone to someone who does not use illicit fentanyl and uses it for chronic pain, we're going to prescribe it differently. We're going to prescribe different doses than we are for someone who uses illicit fentanyl. If someone has carries and they're like housed and they're stable and they're doing really well, they get witness dosing with their carries, but then that's fine. But then if they lose their housing and they're on the streets, they're more likely to be using other illicit drugs to survive. They're more likely to become a target if they've got methadone in their backpack. You know, those risks change. So what we're doing with patients change. And we always want to be articulating that very clearly to patients so they understand what we're doing. We're not punishing you for losing your housing so you lose your carries. That's not what we're doing here. And involving patients as much as we can while being realistic. So it involves like a bit more frank conversations with patients, but that's really, really helpful. That's what I got. I hope that this has been a helpful video for you. Please feel free to continue to practice addiction medicine as best as you can and consult addiction medicine specialists anytime you have any questions. Thank you very much.